Can you see my slides?
Yeah, absolutely correct. Go on.
So I am Dr. Nilufar Fatema Chowdhury, Consultant, Department of Cardiology, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. Thank you, Cardiac Society of India, West Bengal branch, for arranging such a big cardiac imaging conference. I am going to present today adult congenital heart disease with refractory heart failure. My first case is 18 years male, short of breath on exertion, fatigue, which is progressive for 1 year. Patient is cyanosed, SpO2 is 90 in room air, pulse is 78 beat per minute, which is regular, blood pressure 110, 75 millimeter of mercury. First heart sound is splitted, and second heart sound is also fixed splitting. And there is systolic murmur in parasternal region. JBP raised, AWAVE is prominent, hepatomegaly, and mild leg edema. This is the chest X-ray peer view showing cardiomegaly with RV type apex. And the ECG of patient shows short peer interval with delta wave present, so more in favor of WPW syndrome. This is the parasternal long axis view of this patient, which shows the dilated RV, and mode shows good LV systolic function with mild pericardial effusion with a dilated RV. And this is the RV focused modified four-chamber view showing the septal leaflet of the tricuspid valve is more apically placed, and the anterior leaflet of the tricuspid valve is moving very well, and the functional RV is preserved well, and there is a echo dropout in mid interatrial septum. Color flow showing tricuspid regurgitation, and left to right shunt through interatrial septum. And subcostal view confirming the interatrial septum, the interatrial septal defect, and large. This atrial septal defect is large with good mitral and posterior rim, and there is free RVOT and also good aortic rim. TAPSE is normal, so RV function is normal. So my echo diagnosis for my first case is cytosolitis, normal atrioventricular and ventricular arterial connection, absent anomaly type A with atrial septal defect secondary type and moderate tricuspid regurgitation, mild pericardial effusion, good LV systolic and diastolic function, and fair RV systolic function. So my second case is 22 years old female, short of breath on exertion and fatigue, and progressive, which is progressive for 3 years. On examination, pulse is 84 beat per minute regular. Blood pressure is 100/70 millimeter of mercury. First heart sound is splitted. There is systolic murmur in parasternal area. JBP raised, AWAVE prominent, hepatomegaly, and leg edema. So here is also we see the dilated RV, which compressed the LV and good LV systolic function. Here the septal leaflet of the tricuspid valve is more apically placed than my first case, and the anterior leaflet of the tricuspid valve is not moving that much, and the atrialization of the RV is more bigger than my first case, and this part is also dilated, and the functional RV is very small. So the distance between the mitral valve and tricuspid valve around 43 millimeter. And here also we confirm the anterior leaflet is not moving at all. And color flow showing the tricuspid regurgitation. And in subcostal view, the inferior vena cava is dilated, and there is no respiratory variation. So the echo diagnosis for my second case is cytosolitis, normal atrioventricular and ventricular arterial connection, Abstain anomaly type C, severe tricuspid regurgitation, compressed LV with normal LV function, radon diastolic dysfunction of LV, and moderate RV systolic dysfunction. So abstain anomaly, the pathological anatomy is the failure of the delamination of the tricuspid valve leaflet and a more apical displacement of the functional tricuspid annulus, and septal leaflets are more apically displaced than posterior leaflet than anterior leaflet. And dilatation of the arterialization part of the right ventricle, and anterior leaflet, there may be fenestration, redundancy, or tethering, and dilatation of the true anatomical tricuspid valve annulus. The Carpenter classification, we know that the type 1 is the volume of RV is well preserved. So my first case is type 1. And type 2 is a large arterialization of the RV wall, and there is anterior leaflet can freely move. And type C is there is restriction of the anterior leaflet movement. So my second case is type C. And type D is near complete arterialization of the RV. So natural history is prenatal poor prognosis, severity related to the RV and LV function, and late diagnosis is associated with the reduced survival. And arrhythmia, 51% cases are present with arrhythmia, and predictors are the if chest X-ray PAVU shows the cardiothoracic ratio is more than 0.65, and severity of tricuspid valve displacement, more apical displacement, and NOIC class 3-4, cyanosis, severe TR, and younger age at diagnosis. Associated cardiac defects are ASD, which is present in my first case, and PSD, RV outflow tract obstruction, PDA, coarctation of aorta, excessive conduction pathway, that is W syndrome, which is also present in my first case, and corrected TGM. Our next plan will be the cardiac catheterization to look for any other shunt and confirm the diagnosis, and followed by surgery. The indication of surgery is heart failure, cyanosis, and type of surgery is done by ventricular repair, right ventricular exclusion, and total ventricular exclusion, and at last the heart transplantation. Early mortality, the prognosis, the early mortality after surgery is early mortality 1%, survival is good if the surgery done in due time is 76%, and survival if done late, then it came into 20 years time, it came to 46%. 83% may remain in NOIHA class 1 and 2. 34% has no need of any cardiac medication. Problem are the late reoperation and rehospitalization and atrial tachyarrhythmias. Thank you for your patient hearing.